بسم الله الرحمن الرحيم. السلام عليكم أعزائي الطلبة. إن شاء الله اليوم راح نعطي آخر محاضرة in poisoning in children, which include main three important poisoning in children, which is cholinesterase inhibiting insecticide, what we call organophosphate poisoning. And the second subject is iron poisoning. And the last in this lecture is kerosene poisoning. So start with cholinesterase inhibiting insecticide. Pathophysiology. Organophosphate and carbamate both are inhibitor of cholinesterase enzyme. Bind to cholinesterase enzyme, preventing the degradation of acetylcholine. By the way, resulting in accumulation at nerve synapse, which lead to cholinergic crisis. If untreated, this process called aging occurs as soon as 18 hours to 2 to 3 days, so become irreversible. Organophosphate poisoning permanent, causing permanent damage, while carbamate is temporary. This figure shows the nerve ending by the acetylcholinesterase is encircled by a red circle. So this is lead to degradation of acetylcholine to acetate and choline. When there is organophosphate or carbamate, there is inhibition of cholinesterase and there is accumulation of acetylcholine, and this is lead to cholinergic crisis in the acetylcholine receptor and leading to symptoms and signs. The exposure to the organophosphate is either oral through oral ingestion, dermal through the skin, conjunctival through the eye, or through the GIT, or through inhalation, respiratory. The main cause is either agricultural use or accidental ingestion, or due to suicide. Other way is chemical warfare weapon, nerve agents. Case presentation. 6-year-old male child is brought to the emergency department because of diaphoresis, means sweating, excessive sweating, and muscle weakness. On exam, respiratory distress, tachypneic, pinpoint pupil, meiosis, small size pupil, excessive mouth secretion, hypertension, and tachycardia. So, what is the most important point in the history? What is the most likely diagnosis? And how would you treat this condition? So in the history, you have to concentrate about history of exposure, like any ingestion of insecticide in the home, or any spraying of insecticide in the garden. So exposure is very important, any history of exposure. And the diagnosis depending on the clinical feature. Now we discuss the clinical feature in detail, and we discuss the management in detail. Clinical and lab manifestation of organophosphate poisoning. Toxicity is related to the accumulation of acetylcholine at peripheral, nicotinic, muscarinic, and in the CNS. So there are different receptors, either nicotinic receptor, muscarinic receptor, or in the CNS, and in these three sites causing different clinical feature. Muscarinic feature. The abbreviation for this feature is DUMBLE. The D for diarrhea, defecation, U for urination, M for meiosis, B for bronchoria, excessive bronchial secretion, bronchospasm. B, the second B, is for bradycardia. The E for emesis, which is vomiting. The L for lacrimation, excessive lacrimation, and the S for salivation. So these the muscarinic feature. Nicotinic sign and symptoms include muscle weakness, fasciculations, tremors, hypoventilation due to diaphragm paralysis, hypertension, tachycardia, and dysrhythmia. All these are signs which are nicotinic sign and symptoms. CNS effect of organophosphate poisoning include malaise, confusion, delirium, seizures may occur, and lastly, coma. The symptoms caused by carbamate toxicity usually less severe than those seen with organophosphate poisoning. What is the important point is the diagnosis of the organophosphate poisoning is based primarily on history and physical examination finding. This is the main way of diagnosis. The cause of death, respiratory failure combined with depressed CNS and increased respiratory secretion. The definitive diagnosis, this is mainly not need and not practical to do this, is by red blood cell cholinesterase, which is more accurate but less available, and the cholinesterase concentration in the plasma is more sensitive but less specific. The amount of this enzyme in mild cases is 20 to 50% of the normal we find, while in severe cases is less than 10% of the normal. Treatment of organophosphate poisoning. The priority in management first is resuscitation is the mainstay of the management, which include airway, breathing, circulations, so stabilization of the child. Second, atropine is part of the airway, breathing, circulation, as part of the ABC measures to control the symptoms. The third is decontamination of the skin of the gastrointestinal tract, and the fourth is the pralidoxine. Now we discuss each point in detail. For resuscitation, careful attention to the airway and the breathing is very important. Sometimes intubation needed and ventilation if necessary. And we have to concentrate on the fluid and electrolyte replacement of the child. In decontamination of the skin or the GIT. In the skin, you have to wash all exposed skin with soap and water, and immediate removal of all exposed clothing. In GIT decontamination, this must be done within 1 to 2 hours. Also, you have to protect the airway, and you have to have a conscious child, mean Glasgow Coma Scale more than 12. This GIT decontamination done by gastric lavage or activated charcoal. Atropine. Atropine, as we mentioned, is part of the ABC measure to control the symptoms. The atropine antagonizes the muscarinic acetylcholine receptor in organophosphate or carbamate poisoning. The dose is 0.05 mg per kg repeated every 5 to 10 minutes as needed, diluted in 2 ml of normal saline. What is important in atropine treatment is to find a full atropinization, which is the end point, which means for poor air entry in the lung caused by bronchospasm and bronchoria, if we give atropine, the endpoint is the clear chest. If we have hypotension, when we give atropine, you have to reach to systolic blood pressure more than 80 mm mercury. Case of bradycardia, when we give atropine, you have to find heart rate more than 80 beats per minute. Cases of excessive sweating, the endpoint if we give atropine is dry axilla. And the eyes, which pupil, in case of meiosis, we give atropine and the endpoint is pupil no longer in point, so mydriasis. The last is bralidoxine. This drug breaks the bond between the organophosphate and the enzyme. So this is the mechanism of action of bralidoxine. It is effective if used before the bond ages and become permanent. So we have to give this drug before 18 hours to 2 to 3 days before aging process. Bralidoxine is not necessary for carbamate poisoning. The dose is 25 to 50 mg per kg over 5 to 10 minutes, maximum 200 mg per minute. It can be repeated after 1 to 2 hours, then 10 to 12 hours as needed. Now, we finished the organophosphate poisoning. We discuss the important and common poisoning is iron poisoning. Iron was a common cause of childhood poisoning death. The severity of an exposure is related to the amount of elemental iron ingested, and we have many ferrous or iron salt preparation or syrup. In case of ferrous gluconate, this contains about 12% elemental iron, while ferrous sulfate contains 20% elemental iron, while ferrous fumarate contains 33% elemental iron. Pathophysiology of iron poisoning. Iron is directly corrosive to the GIT mucosa, leading to hematemesis, melena, ulceration, infarction, and potential perforation. The toxic dose of iron poisoning, when ingestion more than 40 mg per kg of elemental iron, this referred to medical care for evaluation. While moderate to severe toxicity is typically seen when ingestion of more than 60 mg per kg. Clinical and laboratory manifestations. In case of iron poisoning, there are 4 overlap stages of poisoning. The first stage, the time from time of ingestion from 30 minutes to 6 hours from ingestion. In this stage, GIT symptoms mainly occur: profuse vomiting, diarrhea, often bloody, abdominal pain, and hypovolemic shock. Second stage is from 6 hours to 24 hours. This is called quiescent stage. In this stage, the gastrointestinal symptoms typically have resolved. The third stage from 12 hours to 36 hours. In this stage, multi-system organ failure occurs, which include shock, hepatic and cardiac dysfunction, acute lung injury or acute respiratory distress syndrome, and profound metabolic acidosis. Death occurs most commonly during this stage. And lastly, the fourth stage, which occurs from 4 to 6 weeks. The patient who survive formation of stricture and sign of GI obstruction occur. Investigations. Serum iron level checking 4 to 6 hours after ingestion. If we find the serum iron level less than 500 microgram per deciliter, this indicates low risk of significant toxicity. While if we find the serum iron level more than 500 microgram per deciliter, this indicates significant toxicity happen. An abdominal X-ray may indicate presence of iron tablet because it's radio-opaque. Arterial blood gas analysis, complete blood count, serum glucose level are other investigation in addition to liver function test and coagulation parameters. Treatment of iron poisoning. First is supportive care and close clinical monitoring is important. The airway, breathing, circulation. Second is decontamination. In this point, activated charcoal does not absorb iron. So, the whole bowel irrigation decontamination is the strategy of choice in case of iron poisoning. Third, the antidote for iron poisoning. The antidote for iron poisoning is deferoxamine, a specific chelator of iron. This given through continuous IV infusion at a rate of 15 mg per kg per hour, but there are indications for this deferoxamine. This given if first, when the serum iron concentration after 4 hours, as we mentioned, more than 500 microgram per deciliter, or when there is moderate to severe symptoms regardless of serum iron concentration. The third poisoning in this lecture, which is common and very important, is kerosene poisoning. Kerosene poisoning is the most important manifestation is aspiration pneumonitis via inactivation of type 2 pneumocyte and resulting surfactant deficiency. Aspiration occurs during coughing and vomiting. Aspiration pneumonitis is inversely proportional to hydrocarbon viscosity. Clinical and laboratory manifestations. Local toxicity include defeating of the skin, irritation of the mucous membrane. Second, aspiration pneumonitis is characterized by coughing. The chest X-ray initially be normal, but they often show abnormality within 6 hours of exposure in patients who have aspirated. So, the chest X-ray may show consolidation in the chest X-ray, which is sign of chemical pneumonitis. Fever and leukocytosis are common accompanying signs in patients with pneumonitis. As we mentioned, is chemical pneumonitis. 2 to 3 weeks after exposure, nematocele may appear on chest X-ray, which is a cystic lesion on chest X-ray. Other feature, CNS depression, congestive heart failure, headache, vertigo, ataxia, euphoria, renal and hepatic damage may be seen. This depends on the dose which is ingested and absorption through the GIT. Case presentation: 2-year-old girl brought by her parents to emergency department due to ingestion of kerosene before 2 hours. So, what is the first measure you should take? Do you discharge the child from the hospital? How would you treat her? What is the instruction you should give to the parent? Now we discuss the management of kerosene poisoning. This figure shows the management of hydrocarbon or kerosene poisoning. So if there is hydrocarbon ingestion, this either asymptomatic patient or symptomatic patient. For all patients, you have to remove all clothes and wash the skin. And you have to be careful not do gastric lavage or induce emesis, because this lead or increase the occurrence of aspiration, which is the main pathology of kerosene poisoning. And we have to do chest x-ray. So if the patient is asymptomatic and we do chest x-ray, and this is normal chest x-ray, so you can discharge this patient. You have to observe for 6 hours and then after you can discharge if still asymptomatic after 6 hours. And if the child is asymptomatic and having abnormal chest x-ray and observe for 6 hours, discharge if still asymptomatic, and follow-up can be ensured at home, and admit and observe in others. So if there is no can take care at home, or the patient becoming symptomatic, you have to admit this child. The other is if the patient is symptomatic from the start. So after the initial measures, which is removal all clothes and wash the skin and no gastric lavage or induce emesis, admit this child to the hospital. So all symptomatic patients you have to admit to the hospital. In the hospital, you have to do supportive therapy, which include oxygen. If there is hypoxia, we give oxygen. IV fluid if the patient cannot take oral and the patient dehydrated. And beta-2 agonist if there is wheeze as required. The second point, you have to monitor the respiratory and the CNS status. What is important here, no steroid is indicated and or no prophylactic antibiotic is indicated. Unless there is certain condition, you have to give antibiotic when there is suspicion of super infection. By this, we end the management of hydrocarbon poisoning. Thank you for listening, and please, dear student, don't hesitate to ask me any question if you like or any clear point. Thank you very much.